Good afternoon. My name is Ntuli Kapologwe. I'm the PhD candidate. My supervisors are Dr. Stephen Kibushi and Dr. Albino Kalolo. I'll be taking you through my doctoral lecture on this process and outcome evaluation of health system strengthening initiatives in Tanzania. Before I proceed, I thought I should quickly take you through operational terms. The first one is fidelity of implementation. This is simply the degree to which an initiative is delivered as intended. But the second definition is initiative. In this context, it will be the program, projects, sub-program, or components or elements. Then we have effect. In this context, will be referred to outcome from implementation of an initiative. And health system strengthening, this is simply the process of identifying and implementing the changes in policy and practice in the country's health system. The last definition is health reform. This is simply involvement of the significant purposive effort to improve the performance of health system. So in Tanzania, we have had a number of reforms, and these reforms have been implemented in many years, and notably the reform of 1994, and we had another reform of 2007 when we introduced a primary healthcare development program, and also this is the time when we wrote our health policy. Then we had in 1993 when we introduced the Big Results Now initiative. Then 2017 when we introduced the direct health facility financing. All these reforms are implemented in forms of initiatives, and all of them are geared towards improving the healthcare system. And the health system is defined through the analytical framework which is used by World Health Organization, and it has 6 building blocks. As you can see, the health governance, information system, financing, service delivery. And these blocks are intertwined and they are not linear. All these ones, they are responsible to the people who are at the middle. An evaluation is just a systematic assessment of design, implementation of all results of an initiative for the purposes of learning or decision making. An evaluation should be as systematic and impartial as possible. An evaluation are important for viability, replication, and also sustainability of any initiative, and evaluations are important for improving the decision making and also improving documentation of initiative and helps to manage limited reporting. But evaluations also are good for testing hypotheses and generation of new knowledge. Evaluations are good for ascertaining accountability and transparency. And this is just a simple example. This is the photo which we took in Kigoma, whereby from these variables, about half a kilometers away, there's a health center with no any medicine, especially for family planning. But half of these variables you are saying they are supporting the health finance. So accountability can be ascertained by using the evaluation. And there we have about 6 types of evaluations. The formative evaluation, which is simply is conducted during development of new program or when an existing one is being adapted or modified. And then we have process or implementation evaluation, which determines whether the program initial activities have been implemented as intended. Then we have outcome evaluation, which measures the program effect in the target population by assessing the progress in the outcomes. And we have summative evaluation, a type of evaluation conducted at the end. So there is a thin line between the difference between the summative evaluation and the outcome evaluation. Then we have an impact evaluation, which assesses the program effectiveness in achieving its target goal. And you need to have several programs for you to be able to tell whether the program had an impact or didn't have an impact. And the meta evaluation is a type of evaluation designated or designed to aggregate findings from series of evaluations. So for the purpose of this lecture, I'll be mainly talking about the process and outcome evaluation. Globally and also in Tanzania, very few initiatives get evaluated. Some of the examples of the primary healthcare development program, which lasted for 10 years but never got evaluated. We had health policy of 2007 never got, and the previous health sector strategic plans never got evaluated. But some of the initiatives die on never goes into full scale of implementation without elucidating the reason. So we have a number of, for instance, SMS for Life was one of the best initiatives, but never got evaluated, but died off. Some evaluations that are carried out are main outcome. Most people prefer outcome evaluation, and a very few which are evaluated their process evaluation. So why did I prepare this lecture? It's built on the evidence that many initiatives will not get evaluated, and if they do so, the quality of evaluation is quite very poor. And the process evaluation is highly needed in whatever initiative so that to be able to open the black box, and open outcome evaluation is needed to determine the effects of effective behavior. There are questions which one need to consider before conducting an evaluation. So the first one, why is the evaluation being conducted? The second one, what will be the sources of data? Whether it's through the primary conducting research or secondary data. Then the third one, was the research design or study design optimal for evaluation study? Then what will be the indicators to be measured, both quantitative and qualitative? What are the key questions or hypotheses one to test? How and where the evaluation findings will be used, and how are they going to be disseminated? Who are your stakeholders or audience? Then the context. These are very important questions one need to consider. Then going into the outcome evaluation. The outcome evaluation assesses the effect or effectiveness of an initiative in producing change. Outcome evaluation focuses on difficult questions that ask what happened to the program participant and how much the difference does the program made to the people. Outcome evaluation are undertaken when one wants to assess whether and how well the objectives of the program were met. Then they need a very solid baseline study and findings. So to your right hand side, you can see the outcome. These are the types. We have short-term effects or outcome, then we have intermediate effects or outcome, then we have the long-term effects or outcome. On process evaluation, this is a type of evaluation that determines whether program activities have been implemented as intended and resulted in certain outputs. The process evaluation should begin during program planning and also should continue throughout the program implementation. Helps to ascertain accountability and how to implement the complex interventions. It mainly focuses on these three areas of the logical model, that is inputs, activities, and outputs, and usually aims at capturing the fidelity. And what is fidelity? As I said before, whether the intervention was delivered as intended, and also focuses on the dose, the quantity of intervention implemented. Commonly investigate the reach of intervention. That is, whether the intended audience came into contact with intervention and how. The process evaluation may test a hypothesized causal pathways using quantitative data as well as qualitative data, and they usually are embedded with outcome. But this is not always. There are some of the outcome evaluation are carried out separately, and the also the process evaluation are carried out. Process evaluation intends to open the black box. So this is just to show you the schematic representation which shows both the process and outcome. So if you have the baseline survey, this should be, and also the endline survey, this should result into the outcome evaluation. But in the middle is where the black box is. We need to open up to know how the processes, the activities were carried out to be able to bring about the effect which is an outcome. And the study design, we have number of studies but which are commonly used in cross-sectional studies for simple evaluation, cohort and longitudinal studies. We have before and after, which can be controlled or non-controlled, randomized controlled trials, cross-randomized trials. And the study approach can be qualitative or quantitative, or we can use a mixed approach. So I will I take you through an example of process and outcome evaluation which we did conduct, and that we are looking at the effect of direct health facility financing on health system performance and how it is implemented in the public primary health facilities in Tanzania. So, the direct health facility finance is simply the direct provision of government or non-state funds to health facility to meet operational requirements. And DHFF was introduced in 2017, being part of the major health reforms, like in the other reforms which have been implemented in the past throughout the country. And the concept actually emanated from the policy meeting of 2016, whereby poor quality of services rendered by the primary care facilities was one of the main agenda in that meeting. And there were several hypotheses, one of which was DHFF might be able to improve the autonomy by the frontline workers and also may lead into reduction of delays of service provision and also may reduce chances of misappropriation of funds which are experienced by funds being channeled through the district office. So this is a schematic presentation to show you how this was funds were channeled or dispersed before, whereby they came from the Ministry of Finance of the Treasury, went to the District Council, and the District Council were the ones who were dispersing the funds as per their jurisdiction. But thereafter, after the introduction, so it skipped this box from Ministry of Finance direct to the primary health care facilities across the country. So this study had the three objectives. The first one was to assess the structural quality of maternal health related maternal health services in primary before and after the HF implementation. And the reason why we decided to check the maternal service because so far Tanzania has been struggling in reducing the maternal mortality. At the moment it stands at 556 per 100,000. Some of the structural quality elements were human resources, equipment, instruments, and also buildings. So the second was to measure the level of fidelity and its potential moderators towards DHF implementation. The third one was to see now the association existing between the first and the second objective. So this is one of the first conceptual framework which actually guided the evaluation. At the left-hand side, we have the components of the DHFF, where we have some activities and also inputs, the training of healthcare providers, appointment of the district DHFF coordinator, then we had the guidelines being availed to its facilities. That was the assumption that, or hypothesized that, should this be well implemented, they should be able to lead us to the outcome. And the outcome of interest is today's lectures on the improved structural quality of maternal services. But again, knowing the effects is not enough, but how that effect came into being is now can be studied through the processes which so from here, from the previous slide, the components start, which was shown at the left-hand side. When you combine with potential moderators like participant responsiveness, health facility, governing committee, the context is quite very key. The training, supportive supervision, these should definitely lead you to the, when they are carried under fidelity of implementation, should lead you to the structural clarity. And this study actually used multi-stage, getting the sample size was used multi-stage sampling technique. The first stage was to pick one region from 7 zones. And you see here, we had one region from the Lake Zone, North Zone, Central Zone, Western Zone. The second stage was to pick district councils from each region, whereby we stratified councils into urban and rural, where we picked one of each, and then we had 14 health centers from those 14 district councils and 28 dispensaries. The third stage was to stratify now the facilities into urban and rural, and we randomly actually selected the facilities from each strata using the table of random numbers. The fourth stage now was to pick the study unit. In this case was the facilities, and healthcare providers, where also because we had a mixed objective, we had quantitative approaches and also qualitative approaches. And in sample size determination for structural quality, actually we picked 42 primary healthcare facilities, and these were randomly selected. Whereas for fidelity of implementation, this was a mixed objective. So for the quantitative part, we had 238 healthcare workers who were conveniently sampled as the ones who were present on the day of actually the day of data collection. But the second one was we conducted 14 in-depth interview, but we emphasized to have 28. We reached saturation at 11, but so we added more 3 to be able actually to reach 14, and the participants were purposely selected. So this was a mixed method approach and employing both qualitative and quantitative. And the study design, this was a before-after non-control study design with embedded process evaluation and the midline. So you could see here the before or the baseline study was done in February 2018, whereas the endline August last year, but the process evaluation was done 6 months after the initiation of DHFF, and the study evaluation was 18 months. So the target population, health managers, health providers of primary health care facilities in all 7 regions of Tanzania, while the study population was the cancer harassment management, primary health care facilities, healthcare providers, cancer health support, health facility committee, and the assistant accountant were part of that one. Whereas for a process evaluation where we conducted the fidelity of implementation, is we had the cancer health management team, cancer health. To the right hand side, we have the schematic diagram, which shows the organization of primary health care facilities and also an institutional setup. At the base of community members where the health facility governing committees are coming from. And then we have the community health workers, and we have the primary healthcare management team, where we have the healthcare providers at the dispensary level and at the hospital level. And we have the CHMT being managers to the district healthcare system. My data were collected through structured questionnaire, and also same structured questionnaire. Respondents were interviewed and responses were recorded by research assistants. And for structural quality, we used observation checklists which were adapted from the results-based financing program, which is implemented in 9 regions of Tanzania and more than 48 countries in Africa. And for the fidelity of implementation, literature review, and theory of change, together with fidelity of implementation, were used actually to construct the questionnaires. So I, as a principal investigator, together with 14 trained research assistants, we are trained on mobile data collection, and these questionnaires were configured in Swahili, and were translated into Swahili. And digital recorders were used to record interview conversations. The open data kit system was used to collect data. All selected expertise had GPS sensors so to enhance accountability. So we have this schematic presentation which shows you now, here we have the data enumerator going to the facility, collecting data and sending it to the cloud. Here as a principal investigator, I was able to review and check the data to validate. Should there be mistake, I send it back to the enumerator. Should there be any errors, then I went ahead to conduct data analysis. Then we have the variables. So before DHFF implementation, the independent variables were social demographic, training, location of healthcare facilities, whereas dependent variable were structural quality of maternity. And at that moment when we also drew what we call this theory of change. Then in midline, we had the fidelity of implementation, where independent variables were potential moderators, the training, supportive supervision, activeness of has facility governing committee, whereas dependent variables were affidavit of implementation. For the end line, that was a repeat of the before, and everything was a replica of that one. Looking at the data analysis for structural quality, we had 7 domains structural quality checklist that was borrowed from the results-based financing program. Some of the questions on infectious waste management, obstetric convenience, commodities, availability. On the analysis technique, you had descriptive statistics, PRDT test, logistic integration analysis for checking association, and if you date of implementation, actually mainly focused on adherence. We had a 40 items questionnaire which was divided into 6 domains. The issue of training, availability of guidelines were also included. When we had descriptive statistics and logistic regression analysis. For our qualitative part, we had this 20% structured questionnaire and thematic analysis was used as a means to analyze data. For validity, we use the standardized tool, as you could see, the results-based financing tool. Reliability, we had a pilot study, high internal consistency of 0.8. And for trustworthiness and credibility, the interpretation was achieved through data translation, where we had focus group discussion and in-depth interview, and other researchers are checking repeated interviews. And then dependability, actually, we made sure that this was achieved by making sure that the principal investigator was checked his answers by another reader who was a supervisor, and participation of investigator familiar with the community and culture. And looking into the results, a total of 42 primary healthcare facilities were assessed for structural quality for maternal health services. Of all facilities, 14 were health centers and 28 were dispensaries. And majority of health centers had less than 39 skilled healthcare workers. That's a cutoff point of minimum staff requirement for health centers. And the majority of dispensaries had less than 15. So you can see we had critical shortage of staff. And it's surprising, some of our facilities had critical shortage of human resource for health. For instance, we had 5 dispensaries which had 2 healthcare providers, while 16 dispensaries had 3 healthcare providers. So you can see how critical was the human resource. Now, looking into PRDT test results for changing structural quality of maternal health care services, we find that all the 7 domains which were studied actually had a significant change before and after, except for sterilization of medical equipment. This problem could be due to equipment. These are very durable, so you cannot procure them frequently. But with another actually domain, availability of obstetric images had a negative change before and after, meaning that before there were adequate obstetric images commodities compared to the. But however, overall, there were changes in structural quality before and after. This is also the diagram to show you the changes which happened before and after. So before introduction of DHFF, we found out that the achievement of structural quality was 2.38, whereas after was 30. That was significant, massive significant change. Now looking into other potential confounders, one of which were results-based financing and the innovation of health facilities, which were going hand in hand with this implementation of this research. We found that for those facilities who were neither innovated nor still they showed structural quality change before and after. You can see at the right hand side. And for results-based financing program, those facilities only results-based financing also showed that they had structural quality change before and after, meaning that the results-based financing has also some contribution in the structural quality of facilities apart from the direct health facility balance. With innovated facilities, still the facilities which were not innovated, they did not show which were not innovative, still they showed change in structural quality. Looking into the fidelity of implementation of 238 healthcare providers who were studied, only 88% were aware of the DHFF, and about 76 who had knowledge about DHFF. When looking into logistic regulation, we found that those who are residing in the rural had 8 times more adequate knowledge as compared to those who are residing in the urban. Looking into the fidelity of implementation and adherence, we found out that only 28% of studied healthcare providers had a high fidelity of implementation. And potential moderators of fidelity of implementation were knowledge of healthcare providers, and running into logistic regression model, we found out that having adequate knowledge was strongly associated with high fidelity of implementation of around 80 times. And looking at the association which was existing between now the fidelity of implementation of overall structural quality, we find out that the higher the fidelity of implementation, the higher the structural quality, which is quite very important. Now, looking at the qualitative data, so we studied a number of themes, and one of the themes was improved timely fund utilization, and we found out that the healthcare providers were clearly pointed out that they have seen that there are improvements in terms of planning and doing other things. However, there are others who really thought that this has created some burden because they are not very able to carry out the activities as they used to, and also they also complain of shortage of actually financial management tools. And looking into knowledge, well, it was clearly shown that for those who actually were trained, they explained well that they understood what the DHFF is all about. On the attitude, well, the majority of them, they showed they had positive attitude. On the structural quality, the discussion part, there was a significant increase of structural quality in primary after introduction that you could see from 2.38 to 30. That's massive. This was similar to other studies which was conducted in Kenya, which actually showed the same. But this is also supported by the fact that increasing financial autonomy could be one of the reasons why also helped to reduce all bureaucracies which they experienced in the past. But of all the 7 structural quality domains had significant differences, except obstetric emergency. This contrary to some other studies conducted in Malawi, Mozambique, which show that when you give autonomy to primary health facilities, again, they should be able to have adequate commodities. This might be due to the policy change at the Education Department, which actually started to actually ask for these commodities to be procured centrally and restricting them to be procured locally. But also we have fidelity of implementation of DHFF. 3/4 of healthcare provided adequate knowledge of DHFF implementation, despite the fact that 88% of them were aware. So it means this was similar to another study, of course, when private provider initiated testing in cancer. That showed that being aware doesn't necessarily mean that you'll be knowledgeable about something. This might be due to the use of cascade training approach, which must have compromised the quality of the training. There was a low level of implementation fidelity in primary. Only 28% of healthcare providers had a higher level of fidelity of implementation. This is similar to the study which was conducted by DULAC in the year 2000, who affirms difficulty in achieving higher fidelity of implementation when you have a new initiative. This might have been also caused by failure of some healthcare providers to comprehend implementation due to the cascade training approach and the lack of financial working tools, as pointed out by some of the interviewees. Looking into the relational with the conceptual framework, we find out that the issue of inclusive decision making was found to be key for implementation of digital. This didn't come out early in the study. Similar to the conducted in Tanzania, Kenya, and Pakistan, and this calls for improvement in that component, which we didn't include the abstract of decision making. Then availability of financial working tools in some public. This is similar to also study conducted in Kenya. This could be one of the reasons that deterred others from having high fidelity of implementation, because if you do not have tools at your disposal, then it's quite very difficult. In conclusion, in general, it is clear that DHFF have had an effect on the healthcare system, especially on the structural quality, and irrespective of other factors. This study still demonstrates that there is an effect on the health system performance. Recommendation needs to invest on the commodities for obstetric emergencies, and also to review the policy of the medical science department, but only 25% of healthcare provide high fidelity information. So we need to invest more on this by making sure that all the tools are available to those. On the conceptual framework, these need to be revisited at some point so as to be able to accommodate some other factors which deemed to be necessary. So what are the take-homes? We need to develop the evaluation plan. That should be marked here. That can be followed through so that to make this project sustainable, particularly the DHFF. But before the actual implementation of any initiative, there must be a solid baseline study as foundation for what kind of process. We have seen there are a number of studies I've already done just conduct the end line evaluation. That's not enough. So there will be a lot of assumptions. But then again, decide the degree of separation of integration between processes and evaluation teams. So if you want to integrate, if you want to separate them, but one should learn the pros and cons of doing. Then consider data collection at multiple time points so that to capture changes of. These are the prerequisites if one wants to conduct it. So thank you very much for listening. I get to submit.